We won't take questions immediately after John, because we're now going to hear from another speaker, reflection from a patient representative, but we'll have John and Helen up later on for the panel. So.
Thank you, Sam. And if I can say to John that I found that a very encouraging presentation of the efforts that have been put in to improve the patient experience of treatment. Our next speaker comes into many categories: patient, carer, research worker, but in particular, a lot of her work is with patients who have brain cancer. I'd like to introduce Helen Bulbeck to you.
Thank you. Thanks, Malcolm. Afternoon, everybody. Thank you for inviting me, and it's lovely to see so many other fellow consumers here. Can you hear me at the back? Okay. So, as with all consumers, my story starts with a personal narrative. My daughter was diagnosed with a brain tumour. It was grade 2, but she's had a little baby. She's doing really well. And then 2 years after her diagnosis, I was diagnosed with head and neck cancer. So if you don't mind, I'm going to shift your focus upwards now. I don't know anything about pelvic radiotherapy, so there you go. So out of our experience grew Brains Trust, a brain cancer charity, and we now support patients and carers all over the UK with their diagnosis. What we do is we enable patients and carers to feel resourced and resilient so that they can secure better outcomes for themselves in what is actually a very dark prognosis. And I use that experience to provide consumer voice. I'm on the brain and CNS, CSG. I'm on the supportive care and quality of life subgroup for brain cancer, and also work with John on CT-RAD. And I feel very privileged to be able to represent our community's voice in these ways. So what we do is we create a vision for patients and carers to help them understand how their care should be for them. It's a very personal journey that we stay with our patients and carers and their families. I'm going to talk to you a little bit about how we do that in a minute. One of the key things that we found very useful is actually to move away from the stats and the data about how many people are diagnosed every year with a brain tumour, because as you know, brain cancer is a rare disease and it's not very useful for us when we're applying for grant funding. So what we do is we work with actually how many people are living with this diagnosis. This data is a bit flaky, it's not accurate. It took us 3 years to get to this point from the National Cancer Registry. But it's missing London and the South East, and it doesn't, sorry Barry, but it doesn't cover Scotland. So we're still trying to get the complete picture. But I would argue that actually, you know, if you're looking at research proposals, that maybe this is a shift that you could make when you're looking at the data and you're putting in those vital statistics. It's about the challenges that we know 60,000 people are living with every day as they're facing the muck and bullets of trying to get through life. And we know too that these numbers for all cancer sites are going to increase as time goes on. We've got stratified medicine now, which is treating the biology of cancer rather than just cancer. We've got, Annie mentioned the use of data this morning as a valuable commodity. It's a far richer source of information that we now have at all phases of the cancer patient's journey. And also fundamental to the public healthcare agenda is the no decision about me without me. And the messages that we're getting very clearly from our own community is that there is still too much front-loading of emphasis at the beginning of their journey. One of the resources that we've prepared for our community is we've unpacked the Improving Nice Outcomes guidance for them so that they can see at each phase of their journey. And we've done it in booklets because not everybody wants to see the whole phase mapped out in front of them. But what they should be expecting, what the gold standard is. And it was a very interesting exercise because if you go into the treatment booklet, we've got pages and pages outlined of what they should be expecting from their healthcare team. But as you move down the journey to survivorship, follow-up and palliative care, it's basically that. It's a very thin, poor offer. And that's one of the areas of our work is we're looking at how we can bring additionality and enhance that phase of the journey for our community. So what are the challenges they face? These are not new. They cut across all cancer sites. The difference with brain cancer, of course, is that you know you're going to have the progressive neurological deficit as people move on through the journey. And then for carers. And this information has come out of our daily interactions with patients and carers over the last 10 years. We've run online, we've run offline surveys, in our telephone conversations, in our coaching sessions that we have with them. So we know that they have varying survivorship, that living with uncertainty is really hard for them. The variable trajectory, not knowing which way it's going to go, being with the person that you love, but it's very changed in personality and character. So the disabling complications, the frequency and severity, and crucially for our community, the loss of identity. They look in the mirror one day and they actually don't see the person they thought they were anymore. And then the life context, the resilience, loss of resilience, and lack of ability to cope. And as they move through the cancer pathway, of course, it's very clearly mapped out in the diagnosis and treatment end phases, but after that, they tend to fall off a cliff. And the more that the care is moved to the community, the more fragmented and granular it becomes, and it becomes very hard for somebody to orchestrate, particularly the carer, who finds that they are now taking on a role that they've had no training for, and it was not a job that they applied for. So I would say that 65% of our first contact comes to a carer, from a carer who's actually reached a very dark place and is overwhelmed and doesn't know which way to turn. And no longer are we seeing a pathway where treatment is followed by a cure of end of life, as Sam has referred to, but one which includes rehabilitation in early and late monitoring and patients with active and advanced disease who are actually not at end of life care phase. They may have very many years in the survivorship, the supportive care phase. And this, as you can see, this continuum, the number of patients that are going to be in this phase is going to increase over time. This data did come from Scotland, Barry. It's really useful. I'm going to try and get it for England. So there's a huge opportunity here for patients and carers to work with their clinicians to co-create the journey or the pathway that they want to see. And we believe that if a patient has enough information and is engaged with their care, then they can become the expert on them. And what they'll bring to the table is what is valued and their attitudes to risk and what they're prepared to take on board and what they want to walk away from. And what the clinician does is bring the expertise to the table about what is possible for the patients. So what we do at Brains Trust is we build communities. We build a supportive healthcare community, and it's a community that can drive measurable improvement in brain tumour patients and the carers' understanding of their conditions and their treatment and their care. And our community isn't bound by geographical boundaries. People can transcend online and offline boundaries to reduce fear and isolation. We have a gateway to all kinds of experiential support. They can text, they can type, they can click on links, they can pick up the phone, they can read, and they can share. And then behind this sets very, very tangible resources. One of the latest ones we've produced is How to Hold a Difficult Conversation, which has been co-written by coaches and clinical psychologists, and about how you need to plan to have these discussions. And we know too that the effort spent in researching and delivering interventions that empower patients and carers, give them greater resilience, a sense of well-being and being resourced, and this leads to an improved quality of life, which we know can impact on improved prognosis. So how do we do this? We use a lot of coaching and communication skills. All of our patient support specialists are highly qualified coaches. They go through a rigorous training. And we ask a lot of questions. Using coaching creates shifts, particularly with carers. It moves them from being stuck to feeling in control and to taking charge. It creates resourcefulness, and it's about being able to use the support and the resources that are out there more effectively. And it creates resilience, so they're better able to face things. And for us, it means we can stay very close to our families on this journey. It creates a more meaningful dialogue at every touch point and brings clarity and purpose to the relationship. So these would not be typical of the questions. This is what people get asked day in, day out. And they're what we call phatic phrases. Are you okay? You don't really want, if you're asking that question of a cancer patient or a carer, you actually don't want them to open the floodgates. You'd be there for hours if they were to answer honestly. So these are the sorts of questions that we would ask. And one of the questions we ask every day is, what are you struggling with most? And we feel that patients and carers have a responsibility to bring to the table with their clinicians a specific ask. Very often when you're sitting with a patient or carer in front of you, they are overwhelmed and they are unable to articulate what it is they need help with. So we just keep asking, what are you struggling with most? And we keep asking and asking and asking until we've got a whole list out of them. And then we get them to start prioritising which of these can you influence, which of these do you need to go to your clinical team and ask for help with. And we found that that makes for much more effective consultations, and they go to a consultation or go and see their GP with a specific request. We've done a lot of research about what our community wants. I've just put a couple of the booklets on your tables. I didn't bring enough for everybody because I flew up and I needed to pack some clothes, not fill it with paperwork. But if you want them, you can download them offline, or Pete from Sheffield, if you're here, he's here today, he can send them to you, just come and find him. But if you turn to page 9, what they want, and it was really gratifying to see actually, is two things. They want to know what to expect during the rehabilitation phases of their journey. And they want better mentorship, home care and personal support. And what this actually looks like is they want access to rehabilitation. They want to know where to go in the community. So another of our resources is what we call the Little White Book, and this is one for Sheffield. We're producing them for all over the country, which is a directory of resources to help people who are affected by a brain tumour. They want to be able to get around. Most people with a brain tumour will lose their driving licence, and I've had somebody say to me, actually losing the driving licence was worse than being told they had a brain tumour. They want to feel in control. They want to have more honest discussions and a more equal relationship with their clinicians. They want people to understand that whilst they look normal, actually inside they are far from normal. They want the right information at the right time. And I know for clinicians it's a real issue when you're first giving somebody a diagnosis and you want to give them all the information, but they can't take it on board. I'm having a card waved at me. Okay. And they want to know how to deal with death and dying. And one of the things that we can do to help is to educate them about the difference between palliative and end-of-life care. Because as soon as the patient hears palliation, they think that's it, it's the end of the road. So one of the other things we've done is produce what's called the Neuro-Oncology Rehab Hub, and this is to build the clinical community and to encourage clinicians to actually start talking to each other about the fantastic work that we know is going on outside in your institutions. So the idea of this was to create an online space and presence to support the establishment of a group of experts and to facilitate the sharing of collective intelligence, because our ethos at Brains Trust is that we're none of us as smart as all of us. So we know that patients can bring a lot of additionality to the trial process. The other handout you have on your table, and I have very nearly finished, Sam, is the one with which is badged with CT-RAD. And that shows you at what stages in a clinical trial process, right from ideas generation through to dissemination of results, you can engage with the patient community to make your trials relevant and appropriate. So we're about building communities so that everyone has a meaningful relationship with each other and better conversations, better quality of life, which will lead to an improved prognosis. And we think it's incumbent on everybody here to have the conversations about what we have to do, what do we have to do to forget about the last in order to create a future so that everybody is living with cancer and not surviving with cancer. Thank you.